This is Summit 6, Round 1, Group 6. The topic is the shifting paradigm of physician competency from the perspective of healthcare organizations, and our narrator is Malcolm Cox.
Well, thank you. We had a robust discussion. We tried to frame the discussion in the way that's shown over here. Basically looking at decision making rather than individuals, but how decisions were made for patients and sort of keeping our outcome around the IOM principles of safe, effective, timely care and so on. And so we put together a rather complicated Venn diagram that showed different kinds of decisions from a systemic perspective, starting in the outer big circle, sort of where we are now or in the recent past, showing ill-informed decisions, basically good people making bad decisions much of the time. And then move into the circle here showing evidence-based practice, where the profession has been trying to move in more recent times, that is to make the right kind of decisions. And then beginning to weld together the patient's values and experience of the care that they're given. And the overlap between that circle and this one would be good decisions. Not just right, but actually good. And then the most complex piece, the last circle, that is bringing societal systems and resources to bear on this, with the intersection there, the small little area being the best decisions of all. So that's the sort of framework that we took. Then moving over here, if I can just step beyond Anne, who's doing another task at the moment, is these are the 10 elements that we thought needed to transition from the perspective of the healthcare organization. And they're listed 1 to 10. Just very briefly, we no longer can deal with knowledge alone, the so-called art of medicine, but we really need to move into competency, evidence-based practice. Then secondly, we need to move from individual physicians to a more systemic, societal approach, looking at systems of care. Moving to clinical judgment, it's basically hoping for the best, to move to measurement, metrics, measuring clinical outcomes. The fourth one, moving from individual responsibility to more team and system-based responsibility. The fifth was moving from individuals as the responsible, accountable individual, and oftentimes looking the other way to more shared accountability, dealing with negligent credentialing as one example of that shared systemic accountability. Number 6 would be in the past, we've tended to guard or keep secret data. We hold the data rather than making it as transparent as it needs to be. Number 7, there's been minimal to no feedback to physicians in the past. Now there needs to be continuous and peer feedback as we move forward. Number 8, periodic assessment, moving now to a continuous improvement assessment process linked to improvement in quality. Number 9, this issue of resource insensitivity in the past, where no one has thought about, if you use the dollar here, what's happening in another area that is equally need of support. So we need to move to a much more resource societal sensitivity perspective. And lastly, and perhaps most importantly of all, at least in my personal mind, I'm not sure the groups, is number 10, that is moving from this very physician or expert-centric culture that we have at the moment to a much more patient-centric focus, with improved experience and improved patient outcomes being the critical thing rather than expertise alone. How much time did we take?
New career in Hollywood, I guess.
He didn't get it.
Absolutely.
Got it. I just can't turn this thing off.